Well, hi, everyone. Can everybody hear me okay?
Yes.
Okay, so I'm Dr. Meredith Byers, and I want to welcome everyone who's joining us for our Society of Breast Imaging, or SBI, Summer Series. Tonight, we're talking about breast density and why it's important. And I'm thrilled to be here, and I'm thrilled to have you joining us. And so I want to start by just letting my panelists, we have a wide variety of expertise with us tonight, introduce themselves and tell everybody a little bit about why this topic is important to them. So I think with that said, let's start with Dr. Berg, if you would mind introducing yourself.
So thank you. I've been interested in this topic for a long time. My mother's cancer didn't show up on her mammogram when I was in high school, and she had to have chemotherapy. And I've been working on ways to improve cancer detection and very much aware of dense breast tissues for a long time. My own breasts are dense. My own cancer only showed up on MRI, and that was only because I sought the MRI that it was found. And talking to my doctor, he didn't know much about supplemental screening, and I'd led the Akron trial of screening ultrasound. And so that prompted the development of the website densebreastinfo.org with JoAnn Pushkin and others to try to get information in the hands of patients and providers about supplemental screening and dense breasts and how it can hide cancer.
Wonderful. Thank you for being here. So I think we'll naturally go to Ms. Pushkin, if you'd introduce yourself.
Hi, I'm JoAnn Pushkin. I'm a patient advocate whose own cancer was missed and estimated 5 years in a row, hidden behind dense tissue. And my story became the incentive for New York State's density reform law, which was the very first state to actually inform women that they had dense breasts. And after those letters began to go out, I started to get calls from both patients and their referring physicians who were not clear at all what this letter meant. They didn't know, is she high risk? Should she insist on an MRI? Is it a diagnosis? And it became obvious that informed in the absence of context was not enough. And so it was my pleasure to work with Dr. Berg and others to launch the educational website, densebreastinfo.org.
Wonderful. And we'll definitely circle back to the website during this discussion so people know all the resources available there. Dr. Vincoff, please introduce yourself.
Hi, I'm Nina Vincoff. I am the Chief of Breast Imaging at Northwell Health in New York and also the Vice Chair of our Department for Patient Experience. This is a topic that really crosses, I think, both breast imaging and patient experience. I think it's so important. Advocacy is really important to me, and creating patient-facing information and material so that patients can take control over their own lives and be able to advocate for themselves, I think is really important. And so this is a topic I feel really strongly about. So really excited for today's conversation.
Wonderful. Thank you for being here. So Dr. Zhang, we'll go to you next.
Thank you. I'm Jill Zhang. Right now, I'm a new attending physician breast imager at Einstein, Philadelphia. I did a research project actually during my fellowship at the University of Pennsylvania. We did a survey of all the SBI members, see how they grade breast density. We did see a wide range of grading by our members, and lots of people also think in the future quantitative method may be helpful. So I'm very interested in this topic, and I think hopefully we can come up with a way down the road that can both grade the mask of cancer as well as the risk of the patients down the road of developing breast cancer to quantify the breast density.
Wonderful, and congrats on your first year as an attending. You and I were together last year during your fellowship training, so this is great. I'm excited for you. And Dr. Stipec, we'll go to you next.
Hi, I'm Gretchen, and I am a radiologist in breast imaging at Long Beach Memorial in California, and I've been in private practice for many years. I've also had a breast cancer that did not get seen on mammogram for dense breast, but yeah. So, it's a subject that is just haunts us every day from many perspectives. One, because we want to do more, and then people do more, but then they get exhausted by it and they don't want to continue to do it because they have multiple biopsies. It's just very complex.
I think all of those are extremely important points. And I think what our viewers can hear from us is, first off, this issue is important to us as women, as radiologists, as some of you have mentioned, I'm also a breast cancer survivor. So this touches on many levels, and it's both personal and professional to us. The couple of things I would say as we get started is, first off, if you have comments or questions, please post them. We're happy to answer them. Second, we're going to do this in a very informal fashion. We just want you to have a chance, as if you were asking a colleague at work, hey, what do you think about this? This is your chance for us to talk about what we think about breast density. So we're going to keep it very informal. And also, I'll just put in a plug for Society of Breast Imaging. Many of us have been on the committee for years of doing social media, which we really love, but there are lots of committees that are available to you. And if you want to take a greater role in advocacy in your professional organization, we'd love to have you. So with that said, we have some questions we'll go through. If we get off topic, that's okay. But I'll just start with, what does breast density mean, and what determines your breast density? Is there anybody who wants to start off that discussion? And I'll say to everybody, we do have some graphics we'll share throughout the evening, because I think breast density, a lot of it comes down to the illustrations of demonstrating what we're talking about. So we'll start there.
Meredith, can you share the slide that I made of the categories? That might be a good place to start.
I'd love to do that. And I'll also warn you, as this is my first time on this medium, just bear with me. I'll get there slowly.
So, I mean, breast density, of course, is really defined by how things look on a mammogram, how much fibroglandular tissue there is relative to fat. And most facilities still use a visual assessment of that. But as Dr. Zhang was talking about, there are quantitative tools that can help, that are more consistent. And the new BIRADS, the last BIRADS 5th edition, of course, changed things even further. So here are the 4 categories. We have fatty on the left, mostly gray, and about 10% of women have fatty breasts. Women with scattered fibroglandular density are more prevalent, about 30% of women. And we still see cancer as well in that group of women. And then the women who have dense breasts, what we're really focusing on tonight, are the women who have either heterogeneously dense category C or extremely dense category D breasts on the right hand images. About somewhere around 35% of women have heterogeneously dense breasts, and around, again, 10% of women have extremely dense breasts, decreasing to maybe only 3% as women get older. It is common for women to get less dense at menopause, and that can cause some variability. There's also some radiologist variability. One radiologist might call the same breast heterogeneously dense, another might call it only scattered. And so when we start talking about supplemental screening for women with dense breasts, that can become a problem if 1 year she's told she has heterogeneously dense breasts and she should be getting extra testing, and the next year everything is scattered and fine, and yet it's the same image. That can be a source of confusion. And I think one thing that might be interesting to talk about, I know in our own practice, and this has been recommended at meetings at the SBI, we look at, if we're on the fence about what category to assign visually, we look at last year's report and we try to be consistent just to reduce the confusion for the patient. And I'd be interested to hear if others are doing the same thing.
Yeah, we also look at last year's report, try to be consistent, so the woman doesn't get 2 letters differently in 2 years.
Yeah, we do that as well. We actually had our templates defaulting so that last year's density would actually auto-populate this year's report, and you would have to change it if you wanted to override it. We're now actually using software for our density, and so we have the Volpara density actually auto-populating our report, which you can change it if you want. But I completely agree that I think consistency is really important. It's not only just confusing about, do you have dense breasts, but as we'll talk about when we talk about risk, it might actually take people in or out of a high risk category. And that's really confusing for patients and their doctors. So I thought it was important to be both consistent and to have some kind of objective measure, which is actually why we switched to the software.
So I really like the suggestion from Dr. Berg about looking back to see what previous year's breast density assessment is. And to Dr. Vincoff's point, there are programs out there that will now assess the density for us. And that was one of the things we're going to cover later. But for our, let's say, our residents or fellows, or perhaps our general radiologists who do some breast imaging but are not breast imaging specialists, let's just jump to how do you assess breast density? And aside from looking at previous reports, was there anything that you consider when you're assessing it?
I mean, one thing in addition to just the visual appearance is also sort of where is it dense, if you will. This is something that Tabar has emphasized for a long time that I think we probably would do well to consider more in this country, and that is that if it's just tissue right behind the nipple, that's more ducts, and that's not really glandular tissue, and that really should not be considered dense in and of itself if that's the only area of the breast that's dense. The upper outer quadrant is the most common place to have dense tissue, and now with the newest BI-RADS 5th edition, that is, if it's just one quadrant that's dense and relatively whited out, then that would be considered heterogeneously dense, whereas in prior discussions that wasn't necessarily. And I think it sort of so it depends on where it is, and it may, to some extent, depend on how nodular the tissue is in terms of the risk. So if there's more interspersed fat and it's all concave here and there, that's less likely actually to be a risk factor than if it's very nodular and convex and expanded lobules and whatnot. And again, that's from Tabar's work, but it's quite valid. And I know the group at Mass General and all, they've actually been able to look at mammograms and predict who's going to develop breast cancer better using AI, just looking at the actual mammogram than combining all the risk factors and all the other models and everything else. And density is certainly part of that, but there's more to it that we aren't currently using as much as we may in the future.
I agree. We might be oversimplifying it right now, to only have 4 categories. I think we already have a sense that we're probably oversimplifying it, which is why, the BI-RADS terminology changed. There probably needs to be something more complicated, and the more complicated categorization may be too complicated for humans to do. And I think, it may be a categorization that artificial intelligence is going to help us doing, because it may actually be a scale. And actually a lot of the software give you a scale, but that might not be the right scale. There might be a different scale, but ultimately we may decide, it's a scale that a lot of different factors can play into, and maybe too hard for us to do as radiologists in an objective way.
Right. And there are 2 factors with breast density. I mean, we've sort of been alluding to the fact that it's a risk factor for developing breast cancer, but it also, of course, the bigger issue that maybe we can do something about is that it masks detection of cancer, right? So and that can happen even in scattered density. If there happens to be a non-calcified cancer in the area where there's a little bit of tissue, that it doesn't necessarily take very much, and especially a lobular cancer, which they more diffusely infiltrative as opposed to forming a mass. And all of these are factors, but the combination is really our problem in the sense that these women who have the denser tissue are more likely to develop breast cancer, and they're more likely to have their cancer missed on a mammogram. And so, some of our discussion tonight, of course, will focus on what to do about that. But I just want to mention that early on.
Yeah, actually, that's exactly what our survey showed when we sampled the SBI members. And right now, people want to have a grading system that can both grade masking of cancer as well as quantify risk of developing breast cancer. As you both actually said, it's actually a very complicated system, or would be a very complex system to do. And also based on the BI-RADS 5 edition versus the 4th edition, we actually found people's routine practice pattern is a little bit more towards BI-RADS 5th edition, but that's probably just because that's what the guideline is. But when you give a same imager, especially those just the density in one quadrant, if you give people a BI-RADS 5th edition definition, they grade as heterogeneously dense. And then if you present with the BI-RADS 4th edition category, then most people will downgrade it as not dense. Yeah, there are definitely some confusions here. Also depends on how long people has been in practice. So I think the BI-RADS 4th edition influence is still there in practice.
Definitely.
Jill, that's a really great point. And I think just to sum up this question we just talked about, breast density is more complicated than it visually looks like. I think we'd all agree with that. Second, looking back at prior reports, perhaps using density assessment software for our trainees, residents, and fellows, or those in practice who don't do much breast imaging, asking your colleagues their thought on the breast density is appropriate, because it's subjective at this point, and we're still trying to finalize how we determine our breast density. So it is a subjective assessment. That really leads me into our next discussion question about the good and bad of breast density. You guys have touched on it a little bit, but I just want to make sure when we talk about breast density, I always share anecdotes on these summer series. I tell my patients, sometimes the good of breast density is that's what's holding things up, and my patients appreciate that. The bad of it is it does both increase our risk and increase the difficulty in detecting your breast cancer. So we do want our patients to be aware. When you guys are talking to your patients about breast density, what are you saying to them? And then perhaps after that, we can lead into a discussion of supplemental breast imaging around breast density.
So there are, of course, different state laws that JoAnn might be able to speak to a little bit better, that I think 38 states plus the District of Columbia now require some form of density notification, but it varies from state to state right now, which causes a lot of confusion, especially if patients move. I know in Pennsylvania, we're actually required to put a whole paragraph that just talks about all the different density categories and then tells the patient what she has. But the term, for example, scattered fibroglandular density, we've had patients think that, oh, well, density is density. That means I have dense breasts, which it doesn't. So that's confusing. In our center, if a woman has extremely dense breasts, our template is actually to default that it mentions supplemental screening with ultrasound in that setting at the moment. Although I know based on the trials from the Netherlands and others that we are actually going to start pushing much more for MRI. And again, some of this discussion has to do with insurance, which we can talk about, but there also are state laws, and I don't know how many states that talk about requiring insurance to cover either the tomosynthesis in many states or supplemental screening, sometimes with ultrasound, or sometimes even like in New York and I guess in New Jersey with women with extremely dense breasts, insurance is required to cover MRI. Pennsylvania just also instituted a similar law last year that still has a co-payer deductible though, but does require insurance to cover MRI in women with extremely dense breasts or those who have heterogeneously dense breasts and other risk factors, as well as some other categories that already would get MRI. So it is very confusing landscape, and I think it's hard to tell a patient to go get an MRI, for example, if it's not going to be covered by your insurance. That would be kind of a hard thing. You don't want her to have regrets later on. If she happens to, have a cancer found, I don't want her to have regrets that I didn't do something I could have done. And I think, part of the informed movement, and again, I think many of us can speak to this, but you want the patient to have the choice, to have the sense of control that she can decide to do as much screening as she is comfortable with so that she doesn't have that heartache of having a more advanced cancer at diagnosis, that maybe something could have been done better if she had sought supplemental screening. At least it's a choice. Now, right now, we're not really giving her enough information, I think, in most centers to make that choice, and that's still a problem.
Yeah, I agree. I think, the way that we give people information has a lot, can be improved quite a bit. So even in New York, which is where I practice, actually, you just told me something I didn't know, which is that you have to pay for MRI for people with extremely dense breasts in New York. What I do know about New York is
all
New Jersey. Yeah.
New Jersey requires the insurance to cover, but New York actually requires it for all women with dense breasts.
MRI?
Heterogeneously as well. Insurance.
Ultrasound, yes. I've never heard MRI before. I'm going to be investigating that later on.
It's not dependent on density in New York. It's just if the doctor feels the supplemental screening is medically necessary, it should be covered.
Yeah. So my understanding of what we have in New York is, and listen, I'm so happy to practice in New York. We've had, thank you, JoAnn. We have had, legislation here in New York for almost the entire time that I've been in practice, practically. And But I still think it could go farther, right? Because what we tell people still in New York is that they should talk to their doctors about supplemental screening. We don't tell them what screening to have. And as a result of that, depending on the environment that you work in, some people's doctors want to be the ones to make that decision, and they don't want the radiologist to make that decision. And so to stay out of that argument has been hard for us in radiology. And I will tell you that my reports, the ones that go to people's physicians, they not make a recommendation for supplemental screening. The patient gets a letter in the mail saying they should discuss with their doctor supplemental screening, but we don't specifically recommend ultrasound or MRI because we don't feel like we have the backup to be able to choose one or the other of those two exams or to come down in favor of one or the other. And I actually think it would be really helpful if we could tell patients, you have dense breast, you should have XYZ exam. We don't do that, even in New York where it would be paid for. We tell them to go and talk to their doctor about it.
So I've struggled with that same issue a lot, Nina, and I think at least here it is acceptable to say consider. We don't say recommend because that's a little strong, but we do say consider supplemental screening with MRI in view of risk factors and breast density, or consider supplemental ultrasound if she can't tolerate an MRI, or various things. We will put those words, and that seems to be acceptable to our referring physicians. I actually had a meeting with the family practice person today. It was very helpful. She said, we really would prefer that that was very simple, that if we knew that you're recommending it and the patient was okay with having it, that we could just bless that to be like, if you needed to do a biopsy, that we approve that automatically, you can just do it. We would like it to be simple. We would like to reduce barriers. We don't want patients to have late stage diagnosis. We want to improve screening. So, it was nice to hear that, acknowledging there are some doctors who do want to be paternalistic and control everything. And I think that's the minority of doctors. I think we do have to push it a little bit more than we have. We've been trying to be so politically correct. And there's also limited capacity. I think the reality is we have to train people to do MR. We have to have facilities. We have to have equipment everywhere. We have to have people trained to do ultrasound if they're going to do it. It's not, you can't just flip a switch immediately and offer it to everybody who might benefit from it either.
I'll tell you that from the people that I talk to in our department, if we had the ACR or the SBI giving us a recommendation, we would put that on our reports. We put the American Cancer Society recommendation for high-risk screening with MRI for greater than 20% lifetime risk. We put that on our reports. But because we don't have a recommendation for
Lost you.
We lost ourselves. I think we're back.
We can hear you now.
I wish we had one. If we had a statement that said either to get breast ultrasound or to get MRI, we would include it.
Yeah, I love that idea. I think because right now when we send the letters to the patient, mainly just based on the state regulation requirement, what we include in the letter. And I feel like sometimes it depends on where people were trained. Some people are pro ultrasound, some people are pro MR. And then sometimes the recommendation is a little bit like individual based on your experience. And so I think if we can have a global standard language to include like just a few options for people or the referring physicians to choose from, I think that would be awesome.
I think if you look at like the appropriateness criteria, there's lots of different tests. And we talked about this the night that we were talking about risk assessment, but there's lots of different tests that are considered to be appropriate, but not one that you should recommend above the others. And that makes it really hard when you're trying to be patient-centered in the way that you talk to people, or when you're trying to give clear recommendations to your referrers, to give them choices when they don't really, we're the ones who should be advising them on what the best choice is. When we put it back on them to make the best choice, when they don't really know how to balance those choices. So in our area, everybody gets ultrasound. I don't tell them to get ultrasound. I talked about this the night we were talking about risk assessment. Everyone gets ultrasound. In fact, people that aren't dense get ultrasound. Fully 60% of my screening population has ultrasound on the same day.
And that's not really appropriate, right? So,
right. So like what I want to do is to be able to give them recommendations. So maybe they'll actually, order appropriately. So instead they just make it up, and the patients are very demanding about ultrasound here, whether they have dense breasts or not. So everybody gets ultrasound.
Well, I do think that the data for MRI are, of course, only getting stronger. And then I think the limitation has, again, been a capacity issue more than anything else. I mean, I think if there were the capacity right now, then the SBI would come down with a very hard statement to do MRI in a much broader population. But I think there is limited capacity. Doing abbreviated MRI is somewhat of an option, but right now that's limited by the lack of a CPT code and facilities having to navigate maybe charging patients out of pocket for that exam. It's being done a lot of places. I know we're looking at a modifier code to put on an MR exam, and maybe that seems like it should work, but it's a challenge to navigate all of that. Without question, MRI is a much better test at detecting cancer, somewhere between 10 and 15 per thousand after a normal mammogram, where we find about, 5 per thousand with a mammogram alone. Ultrasound is only about 1 to 2 more per thousand that we find. And there are many more false positives with ultrasound. A lot of the biopsies turn out to be benign. You know, I'm pushing back on a lot of the BIRADS 3, and there's actually a review article coming out in Journal of Breast Imaging soon that I put together all the data from all the studies, including the Akron study. Really, BIRADS 3 on ultrasound, you can see it in a year because there's so few malignancies. It's almost all complicated cysts with debris and fibroadenomas, and we really shouldn't be doing 6-month follow-ups on that. And we shouldn't be causing extra testing for that, or biopsies especially. And so, you know, you can make ultrasound better at that level, maybe reducing false positives, but you're still not going to find all the sub-centimeter cancers. It's pretty good right around a centimeter. It isn't so great much below that. And that's where MRI is better. And that's where I think, you know, preliminary data are looking very encouraging for contrast-enhanced mammography. It's not currently FDA approved for screening, but it is performing very similarly to MRI. And that's something then that can be implemented in the breast center, not on separate equipment, just an upgrade with low-cost contrast. I'm very optimistic about the future with that.
Yeah, I think I did my fellowship at Penn, and most of our dense breast screening is abbreviated MRI. And some of the women, even though we charge a very small amount, $299 out of pocket, but lots of women have very high deductible of their insurance. So like if they go through the routine MR with the insurance, they can actually not afford it because their deductible is like thousands. So they actually really appreciate they have the opportunity to just pay a very small amount out of pocket and get those MRI screening.
That's such a great point. I mean, we talk about things being, the cost sharing is a really important thing. So it's not, you can't just have insurance coverage. You have to make sure that there's no cost sharing on the patient side. It has to be treated like a wellness visit, that you don't have cost sharing. If there's going to be cost sharing, then it doesn't really matter whether your insurance covers it if you have a huge deductible that you have to meet first.
And that's the problem. Everybody's
Oh, sorry. I was going to say, it might be best if it's not free.
Yeah, everybody seems to have like thousands of dollars of deductible. So maybe, JoAnn, you can push for that, because that's one of the big problems, that you send people down these paths with, again, a Tyrer-Cuzick score that is really not a great score. I mean, it's not that reliable. And we're using that to send people down these paths that are very costly. Well, and then also cause exhaustion, right? Because they have the MRI, and then maybe they need an ultrasound, maybe they need a biopsy, and so on and so forth.
And one of the challenges was, and here we have New York, we thought we just had the best insurance law in the world. And it turns out there are many plans that are exempt from state laws. So even with a great law, self-funded plans are exempt. And so what are self-funded plans? I didn't even know. So they're the most common type of plans now that people sign up for. 60 to 80% of new insurance plans are self-funded plans. Why? They're cheap. Why are they cheap? Because they don't cover what's mandated by the state. So even in a state with a great insurance law, there will be insurance policies that don't have to abide by that state law. Federal plans don't have to, or an out-of-state plan doesn't have to. So very frustrating. I mean, I'm getting emails every week from women very frustrated in New York who are not having their supplemental screening covered.
Well, it's a problem even for mammography alone, because when you're called back for diagnostic testing, you're stuck with that same big bill. And so we have patients who don't come in for their recall or their ultrasound because they don't want to pay for it. And so, you know, it sort of defeats the purpose, obviously, of screening at all if you're not going to follow through on the results. But I understand. I mean, even for a unilateral, just like one tomosynthesis view as a diagnostic image, I think we bill something like $750, which after our own insurance is about $450 to the patient. And yeah, that's a lot.
Yeah, I have patients say the same thing. Like they came for 1 year for a diagnostic, and we require short-term follow-up, and they don't come back. They just come back for screening because they said, I don't want to get a bill. I got it last time. Even when we try to convince them to convert it into diagnostic, they just don't want to do it.
And our patients know, they're an educated population. They know that if the diagnostic is not affordable, they'll come back for the screen because they want that opportunity to be screened without having to foot the bill. So I think, just to summarize, because we've gone over a lot of stuff here, is that first off, the guidelines, at least for the majority, if not even for us in subspecialty practice, the guidelines are a little bit muddy in terms of what's the right thing to do for these patients. And if they're muddy for us, they're muddy for our patients who don't know what the right step is. And as Nina mentioned, in New York, perhaps they're all going to want an ultrasound. Where I am in Missouri, we split it kind of half and half between ultrasound and breast MRI. And if you're in a place that does contrast enhanced mammography or abbreviated MRI, that's a choice for you where it's not where we are. So the choices are widely varied. I think we want our referring colleagues to know that we think we are the experts, and we'd like them to ask what we think they should do for their patients rather than feeling the burden of having to decide it on their own. We want to be their friend in this process and help them work through this instead of having to try to figure it out and us having to question it. And then our patients, we need to connect with them and tell them this is what we think you need because of your breast density, because of your risk factors, because of your risk assessment. But talk with them about options because cost is an issue and accessibility is an issue. And it doesn't do us or them any good not to be able to give them the right test that works for them. Right in the end, we want everybody screened appropriately. And so we have to partner with our patients to find what that answer is. And it may be different for patient A than patient B. And that's an important message. We do have to individualize patients' care based on what works for them, for their physician, and for their pocketbook.
That's very good points. I wanted to ask the question because I think both Gretchen and Nina mentioned the issue about Tyrer-Cuzick and risk assessment and whatnot. And I know it's a little beyond our topic today, but up front, we probably want to capture the women who are high risk at least and get them to an MRI based on the 2007 guideline from the American Cancer Society. But it's not so simple. It's not so simple to do Tyrer-Cuzick calculation on people. It's not. I would be interested to hear exactly how you're doing this in practice. We have some back of the envelope guidance that gets us there pretty close to there without doing the actual model. But obviously, as a woman gets older, her lifetime risk decreases. And I'd also be interested to hear, like, is there an age where you all stop doing MRI in your practice? We sort of said 75, but it's interesting. I'd be interested to hear other people's perspectives.
We talked about this a little bit the night that we were talking about risk assessment. I mean, in our practice, we actually do the full Tyrer-Cuzick risk on every single person who walks in the door. Our technologists, year one's really difficult. Year one is time consuming. It's our technologists that are asking the questions. We have the patients fill out a piece of paper first, but if you only enter that information, you're going to lose a lot of really critical information. So that's the starting point. But then someone needs to talk them through their answers and make sure that they really understood the questions. And then that information gets entered in, and then the Volpara, we take our Volpara density and feed that into the TC score. So we're using TC8, and then the TC8 score goes into our reports. And we feel, maybe I'm crazy, but I like to have backup with the organization that tells me what to do. So I'm totally comfortable if my TC score is greater than 20% lifetime risk, quoting the American Cancer Society and saying you should have MRI. And in fact, my nurses, when they call you with your results, we have actually nurses that call with screening, both positives and negatives. So we do send letters, of course, but we call every patient who has a screening mammogram. When our nurses call, they tell the patients on the phone that they're high risk. They don't discuss density with them because density feels too complicated to discuss with them, but they feel very comfortable discussing risk. And so they'll discuss risk and tell them if they're high risk that they should talk to their doctor about having MRI.
What's everybody else doing?
When I was at Penn, I think we partner with the referring physicians, especially the OBGYNs, and then so we actually don't screen the patient ourselves, but we try to encourage our referring physicians. And we also have a big risk assessment center at our cancer center. So we have some nurse practitioners, they do that, and we also call them breast specialists. So we basically try to just partner with our referring physicians for the risk assessment.
Yeah, at my center, we have MagView, and everybody who walks in gets a tablet, and they fill it out, and then the technologist is supposed to go over it in the room. But still, sometimes we find out that there are some mistakes. Sometimes it doesn't dive. Was it really your sister, or it wasn't a biological sister? People put in mistakes, so that happens. But yeah, then the process is the same as Nina's.
We MagView as well, so I'm sure our processes are very similar because we that's what we do.
Yeah, and then one thing I would say is that Volpara, I don't know about you guys, but I don't feel like it's always accurate.
No, I allow our group to override, but I would say we probably override 1 to 2% of cases at most.
Yeah,
have you found it's more than that?
I don't know. I mean, I guess less than 5%, but it does happen. Yeah. And it's just weird to me because it should be so consistent, right? Because it's a computer, so you'd think. The other resistance that we get is sometimes referring physicians, I think because there's not clear guidelines, feel that we're not telling them the truth. Kind of like when the US guidelines came out of, do it every other year, do mammograms every other year. And they maybe felt that we as radiologists were trying to, do more than we.
So I agree. And here's how you fight that. Here's how you fight that. So the first year that we did this, that we started actually having the nurse navigators tell people their TC risk, I got a lot of pushback. Mm-hmm. So I didn't quote anybody else's data. I did Northwell data. That first year out of the MRs that we did, and these are MRs that were supplemental on top of a normal mammo and usually a normal sono, right? Because most of my patients have mammo and sono. We were finding 11 cancers per 1,000 in that high-risk population. Wow. Now I can basically be like, it's working. It's not just working in general. It's not just working on studies that other people have done. It's working here in our health system. We're finding additional cancers. And I don't get pushback anymore.
Excellent.
So we're doing similar to you guys. We use a tablet system, and we're getting the TC8 risk assessment. And this is a good point. Everything you guys have said. The first year, very challenging. Subsequent years, easier. Sometimes I see a patient's risk assessment, and they've listed every family member as having breast cancer. And I think they're frustrated with my process, which I understand. So we do try to do follow back, and we also call to follow up with the patients. So there are various things we all have to do, right, to navigate this process. But I think it's reassuring to hear that we're not doing it alone. You guys are in the same boat. For your patients who come back at increased risk, let's pivot now, because so much of that can be based on our breast density, into supplemental screening and talking about what we do at our individual practices or in the US in general, and perhaps we do internationally, because I know that we've got data on that. So I'll just turn the floor over to whoever wants to talk.
I mean, JoAnn, I think it'd be interesting to hear, you have the summary of the international. I don't know if you want to show the slide or if that's, I don't want to push the technology.
I'll share the screen. You guys just navigate me, okay?
I'd love to hear the international.
So at the bottom, share. Oh, are you going to put it up, Meredith, or did you want me to?
Actually, if you want to, that would be great. I have it as a backup.
Okay, let's see.
While she's doing that, do you all consider tomosynthesis to be supplemental, or do you consider that to just be mammography? Because we just consider that to be mammography now.
It's standard of care, yeah.
Yeah, and I hope that all of our people listening hear that we believe 3D imaging or tomosynthesis to be our standard of care. We really want to push every institution and every practitioner to move towards that.
Yes. And I think it's over 58% of the facilities at least have some. I don't know what percentage of that was as of actually more than a year ago now. So it is more than half, I think, of patients who can get it, at least at this point, which then kind of by default becomes the standard of care by definition.
And when you look at the AC criteria, they actually talk about tomosynthesis as being a supplemental test that you could do in the setting of dense breasts. And I'd be interested to hear after we talk about this, how all of you think tomo performs in patients with dense breasts. But
that's a good, yeah. Good question. So JoAnn, go ahead.
Oh, okay, you can see the screen. So this is a partial table of what is on the website. So we have our experts in Europe, and we asked what was going on in each of their countries. And you can see that it varies by country. Again, it's only a partial list. So the ages that they start and stop vary, although within a small window. Generally recommended screening interval other than Greece is every 2 years there. The breast density in the medical mammography reports, not all countries include that. You'll see Germany doesn't, Iceland doesn't, you don't see Republic of Ireland and Italy and the UK on there. And in the UK and Ireland, interestingly enough, density is not even recorded at the time of the mammo. So if the patient asks, there's not even a report that the radiographer can refer to. And then screening guidelines for dense breasts also vary, as you see. In Austria and Hungary are the only two where it's standard for the woman to have an ultrasound after. And in France and Croatia, it's recommended. And then there are some that have no national guidelines, and it's a little bit all over the place from there. Canada also seems to vary by province. I don't have a map or a table for them. They have varying levels of informed by province, and there's some supplemental screening again by province. So it's sort of piecemeal as it is in the United States.
And one of the things, I mean, to help answer the question that was posed about tomosynthesis is actually not at all standard yet in Europe, right? We found that very few facilities, very few countries are doing very much tomosynthesis at all. Instead, they have gone with more supplemental screening, either with ultrasound or in some countries, they're also doing a lot of MRI. In France and Germany and the Netherlands, they're doing quite a bit now, more MRI screening. So it's interesting. And at least, you know, the perspective, and when we summarized it in the recent AJR review article that came out in February, the data for tomosynthesis, you know, it does help in heterogeneously dense breasts, but the help is about 1 to 2 cancers more per 1,000, where there are, as we sort of mentioned, somewhere between 10 and 15 more cancers per 1,000 to find if you did an MRI, for example. So it's not much help. In extremely dense breasts, it probably doesn't increase cancer detection at all, significantly anyway. We all have the anecdotal case, maybe distortion will show up, but it doesn't really help unless there's some internal contrast between the fat and the dense mass that you could see it better with the tomosynthesis. So it's a problem in extremely dense breasts that really doesn't address, to my satisfaction, I think to our global satisfaction, the issue with extremely dense breasts at all. Non-calcified cancers are really the problem because they can blend in with the tissue.
I think that's really important for patients to understand, because I think there's a lot of, you know, miscommunication out there about what 3D mammography is and what it can and can't do. And I think, you know, I'm sure we don't have a lot of patients listening to this talk tonight, but I think we should all be thinking about ways to sort of adjust the story around 3D mammography. Yes, I believe it should be the standard of care. It's my standard of care, but it's not the tool. It's nowhere near the best tool, if it even is a tool that should be thought about.
It's like a floor, right? It's a floor, but it's not a very high one.
Yeah, and I don't think that's getting communicated to women. I think, you know, there was a lot of hullabaloo around 3D mammography, but I don't think women really understand what it does and what it doesn't do so well.
Well, I think we found there was a survey that we actually did with referring physicians and found that they hugely overestimated the benefit of tomosynthesis. They thought that was all you needed in dense breasts, and that was great, and the be all and end all. I mean, the advertising must have been great during the Super Bowl or whatever, right? Early on. It's just, it was oversold, just like mammography, unfortunately, was oversold, and we still have a big problem in women with dense breasts, especially.
We don't want 3D mammography to get in the way of us really getting women the supplemental screening that they need, because so many people are focused on that. And I actually think that's a significant issue on patients that I just talked to, you know, when we just get into conversations about, you know, dense breasts and, you know, I think there's a lot of misunderstanding, even amongst educated patients, people who are being really proactive about what these tests can do and what they can't.
But I think it's interesting in Europe. I think they basically reached the conclusion that, yeah, it's a little bit better, but it's not worth the money to go that route, right? And that's why they're going on to the other tests that find more cancers and have focused on that approach instead. It's interesting.
Did you say that in England and Ireland, they don't include breast density in their reports?
Correct.
Right. At all? Like no BI-RADS classification of breast density in the report?
And how do they calculate the risk factors, like in terms of like the thyroid and stuff? They don't take the density into consideration, or do they not calculate risk?
Yeah.
Or
ironically, of course, Cusick is from UK, right? So,
yes.
I don't think they do a lot. I mean, they don't do a lot of supplemental screening with MRI either. It's all part of the same package, and they don't. In the UK, they screen every 3 years with mammography, not every 2.
So I just wanted to ask, because in my practice, we definitely, take care of the people who have the high risk, but we're just not sure always what to do with people with intermediate risks and dense breasts. Do you guys have a standard that you apply, or is it kind of a case-by-case basis? Or
well, I think one area where there's great clarity, I feel, is women with personal history of breast cancer. The American College of Radiology, Debbie Monticello's paper did come out, I think 2018 or 19, that really made it quite clear that at least if a woman was diagnosed at a young age, below age 50, or had dense breasts, that she really should consider supplemental screening with MRI, because we know that in addition to breast density being a problem, we actually have problems in women with personal history of breast cancer missing more cancers, even when the breasts aren't dense. And women who are diagnosed at a younger age are more likely to have recurrence. And so all of those things factor into that statement, but it is a very clear statement out there in women who are in that kind of intermediate category.
It's clear to us, right? It's clear to the people that are in this conversation. But is it clear to the women who have had breast cancer?
No.
How good a job are we doing at communicating the rules that we've all decided? So we've
Not
decided
at all. I just want to be very clear.
50, or you have dense breasts and you have a history of breast cancer, you should have MRI. But do the people who've actually had breast cancer, do they know that, or is it just all of us in the radiology community that know that? That's what worries me.
Yeah, but who should be telling them? And so this is the conversation that we have with their referring physician,
surgeons, oncologists.
Yeah. Well, I've tried to communicate that to our surgeons, just that one piece of information that you just gave about how if you had breast cancer at a young age, or if you had breast cancer and a history of breast cancer and you have dense breasts, that you should have MRI. I communicated that directly to our breast cancer team, and they're pretty good about that. And I think you're right. Most of those patients continue to be followed even years later by breast specialists. Not forever though.
Right.
I think we have problems like, the women who were diagnosed 15 years ago or whatever, they were certainly never told, and they still would be eligible for it. And, we do have a responsibility. And I know within our own center at University of Pittsburgh, we don't always tell everybody, just because we, again, don't have capacity to do MRI in everybody. And so it's a little bit of a problem. We try to at least do the ones who were diagnosed at a young age and dense. We try to recommend it explicitly. And we're expanding, again, our capacity for abbreviated MRI and contrast mammography and all are going to be options, but it is a problem. There is a limited capacity, and that's an issue. I think the other maybe category where there's some clarity, at least, is prior lobular carcinoma in situ. I think they're pretty compelling data. There are lots of published papers using MRI in those women, and they tend to have dense breasts also. And they also are at higher risk of developing invasive lobular carcinoma. And those are harder to see on the mammogram. So I think that's clear, and that's a pretty small population of women. I think we can at least be clear on those categories.
Yeah, so during my fellowship at Penn, we do a lot of abbreviated MRI just for dense breast screening. And then one thing I want to mention is like when you increase the capacity of MR, not just MR, you also have to increase the capacity of MR guided biopsy, because when we are actually catching up with the COVID delays, and so our chairman coming at 6 a.m. to do MR biopsies, so we have 2 MR biopsy, a day. Because when you have more MR, you are naturally going to catch up with the biopsy slots. So for facility to catch up to increase their capacity, you do have to keep that in mind as well.
So not to harp on a thing, but contrast mammography also can help with that, because we realized as we got the capacity to do contrast enhanced mammography biopsy, hey, we could send our MR biopsies to have a contrast mammogram biopsy instead, and we could decrease our backlog for MR biopsies. So I think that can also help with the workflow in that respect.
Wendie, that was one of the questions that popped up from one of our viewers. Was I've seen a couple of questions. First, that just remind everybody, not everybody is using tomosynthesis for every patient, and
Right.
especially in our more rural communities, that's not an option. So we do have to be sensitive to that. The second question was, how are you using contrast enhanced mammography? And so perhaps you could talk about your workflow and where your algorithm and where you're incorporating it.
Everything we're doing is still under research protocols, but we are doing it for screening women with a personal history of breast cancer and work funded by the Breast Cancer Research Foundation. And we're also doing some preliminary studies for screening women who meet the criteria for MR in Pennsylvania. So women who have extremely dense breasts, or women who have heterogeneously dense breasts and either first degree or 2 second degree relatives. We're doing a research study of contrast mammography screening for them. Dr. Zulli is also leading a study of doing CEM prior to biopsy. In part, that was to learn more and see more and get more experience, but also has the potential, again, to address the low suspicion lesions, the BI-RADS 4A and B, that maybe we don't need to do a biopsy for a lot of those masses, especially that if they don't enhance. We could argue whether it's more or less invasive to have a contrast mammogram versus an ultrasound biopsy, but at any rate, it's of interest, and it's worth understanding how it performs in that sense, and to reduce false positives again.
One of the things that's interesting for me, and I'd be interested to hear what your answer is to this, is so where we are for these high-risk patients, they'll have like mammography and ultrasound one time a year, and then they'll have MRI alternating 6 months. So when you put contrast mammography into that algorithm, my gut is get rid of the mammo, get rid of the sono.
Well,
if you want to be seen every 6 months, have the most sensitive and specific test twice a year. Don't have one test that's not very sensitive or specific, and then 6 months later have the test that is. Why not? If you're going to come in twice a year, have a great test twice a year.
Well, and you actually raised a really good and broader point, which is, at least in Europe, there's a lot of pushback on even doing mammography at all in women who are getting an MRI screen. For example, BRCA1, it really has no benefit to do the mammogram at least until age 45 in that patient population. It probably, maybe it's a little more worthwhile in BRCA2 mutation carriers, but it is worth considering that maybe we don't need the mammogram if you're getting an MRI. And similarly, I think with contrast mammogram, we're not going to need. It basically functions like an MRI in terms of what you get out of it. So, it's a little early. We need more experience with it, but I think it has the potential to really improve workflows as well. And you really don't need then diagnostic testing. You can just go straight to biopsy if you see an enhancing finding on the CEM, just like you do on an MRI. So you eliminate a lot of that extra views and ultrasound. So it can be much more efficient. There was a pop-up question I saw about BRCA1 in men.
The question was, if men with BRCA1 mutation, should they be getting a mammogram? Thank you for that question.
I mean, I think yes is the sort of short answer, but that's depends if they have enough breast tissue to image. It's controversial, and it's controversial enough in women, even as I said, under age 45 with BRCA1. We certainly don't go with an MRI in men. I'll put it that way. So. I don't know what other people are doing.
I think we're on the same page. Yes, maybe. And in some ways, it's an individual decision based on the patient's body habitus and their age of life, where they are.
BRCA2, they tend to get cancers at older age a little bit. I don't know if the same is true for sure in men, but I know that we do see those a little bit more often for screening in men.
Same. So, okay, guys, we've covered a wide variety of topics, and this has been great. This is exactly what I think we all wanted to get out of this discussion, is to see what questions we have and also what questions our viewers have and what our input is on it. I'm going to leave with one question. I'd love everybody just to throw in what they think. What's the future of breast density? Where are we going next? What's going to happen? What should we be looking for? What do we have to look forward to?
I don't know. I think that what's going to happen is that we're going to get amazing risk assessment tools that are going to be artificial intelligence based. like all the studies that you have been coming out of MIT, that genius, what's her name, Regina Barzilay. And that's what's going to happen. We're going to get amazing risk assessment from that. And so that the density is just going to be kind of part of that.
I really hope so, because that's my hope, is that we get to that place, because breast density alone, I think why it's been such a struggle is because there are so many choices and none of them are perfect. And both in terms of, how much they cost and how easy they are to do and access and everything else. I hope that we get to the point that density just folds into the bigger risk assessment conversation. And then we come up with really clear algorithms around risk, and we don't separate it into density and risk as if they're two different things. And we get to a place where they sort of merge and become one with the tools that you're talking about.
I think it's like density is a little more complicated in just a quantitative way, because like not just the overall dense breast tissue, we also want to analyze the pragma patterns of the patient and evaluate their risk and everything. So I think AI potentially can have the potential to help us figure this out. We need a little bit more complicated system to capture both the cancer masking, the complexity of the breast tissue, and the risk of breast cancer.
For myself, I'm hoping that we have one simple screening tool that we don't have to worry about all the supplemental screening, that we can really replace the standard mammogram with something that's simpler. I'd rather not have iodinated contrast myself. It's not a really fun experience, although I have to share a story. I heard it from a patient. I've been recruiting for my studies all weekend, and the patient told me about a person in front of her getting a CT scan who was in her 90s, and they were injecting contrast, and she squeezed the ball, said, "Stop, stop, stop." And the tech said, "What's wrong?" And she said, "Honey, I haven't felt that way for a long time." So, you could argue, but I wish we had something simpler that did not require any contrast, that would find all the cancers early so that we don't have such difficult treatment for patients and they have a good outcome. I mean, that's really my hope for the future. And I think, honestly, it's not just limited to women with dense breasts. That's part of the problem. We can miss cancers in breasts that aren't dense, too. We really need better tools.
And I think from the patient perspective, I mean, everything you're saying, of course, risk assessment, masking, all of that taking it into account, because I think from the patient perspective, and I think I speak for all the advocates who fought for laws in their states, we really felt like the burden was on us to try to figure out what this meant, what we should do, the right questions to ask. Like, we would feel so much better to know, like, you all have that. It's all, you've got a system and you've got the supplemental screening worked out and the risk assessment, because right now it really feels very much like it's on our shoulders to know what to ask, particularly if you're getting a mammogram in a setting where it's batch read and you never speak to that radiologist. So that it's another year before you go back to your doctor with a report and you've not spoken to anybody.
And when you ask patients to advocate for themselves, it just really exaggerates the healthcare disparities, right? I mean, you can't.
Absolutely.
If we really, if we want to try to address, disparities in healthcare, we can't be asking patients to advocate for themselves. That's not a reasonable thing to ask patients to do. If we really care about healthcare disparities, we need to have universal recommendations that patients can rely on, and then don't have to do the work.
Well, and access, and this gets back to the question about standard of care. I mean, you don't want people not to get a mammogram. If they can only get a regular mammogram and not a tomosynthesis, they should still get the mammogram. And, we don't want to have more barriers, if you will, but we should do a lot better in making it all accessible. And that includes better screening to start with. And maybe we can reduce the screening. Maybe we can go to every other year MRI in women who aren't high risk and do better than what we do with all this mammogram plus supplemental screening and all. I mean, I think we need to start thinking outside the box. I know Chris Comstock is planning some trials along that in that way, and I hope that those get going soon, because that's, we need to think about how to reduce what we're doing, but get to more people in a more effective way.
And I think radiologists should be the one to lead the charge to decide what the best use is for these tests, and we can't. It's nice to have the backup of laws that come from states, but I really think that, we shouldn't let it get to that. Like, radiologists should be out there, leading the charge for this stuff, for making sure that people have access and and that we're doing the thing that's evidence-based.
Agreed. The only problem is we can't be seen as self-interested, and that's one of the problems with some of the task force and everything else. We're kind of not allowed to be part of it because we're seen as conflicted, and it's how we make our salary.
We're the experts.
But I don't
fight back against that. We're the experts. You can't.
Agreed.
And how ridiculous that your expert opinion would be not shared with the patient. I mean, right? So I mean, why am I coming to you if I can't get to hear what's in your head? Yeah.
Well, listen, guys, your opinions have been invaluable tonight. I think where we can all land is that what we want is that both our patients and our referring colleagues have a radiologist they can trust and ask these questions to, and that we as radiologists have some clear guidelines on what to tell our patients and our referring practitioners. And I totally agree. It's up to us to make that happen. That's our mission as we move forward. We are drawing close to the end on time. I first just want to say thank you to everybody who was here tonight. I mean, the wealth of experience was unbelievable, and your voices were very much appreciated. I want to encourage everybody to follow SBI on social media, Facebook, Twitter. Join SBI if you haven't already. We're a great group. We're fun people. Look at us. Volunteer for one of our committees. Please attend our meetings. But in general, just join us for these conversations. They're really worth everybody's time. And we're just so appreciative that you joined us tonight. With that said, I want to say thank you to all of my panelists tonight. Thank you for being here. Thank you for sharing your information. And we wish everybody a good night.
Thank you so much, Meredith. It was really a pleasure.
This is great as always. All right, we throw the breast happy hour. That's always my ending. Bye, everyone.
Bye-bye. Good night.
Good night.